taken 3 sentences from the summary of reproducible research Coursera massive online open course because I find them quite inspiring. So the idea is to make data analysis and more generally scientific claims reproducible. And so we should be able to deliver our analysis along with the code we used. And because the need for reproducibility is increasing dramatically as data analysis become more and more complex, involving larger data sets. And when these data sets are not so big, like in our case, when sophisticated computations are in place, and of course, reproducibility makes an analysis more useful to others because the data and codes are available and could be compared. So we used a bunch of tools for making this happen. So we used GitHub as a platform for sharing our code. In that case, I used my personal account, but of course we can provide the same process storing the data and the codes in the Harmony website, for instance, or in a GitHub repository in the name of the initiative. And of course, since we are talking about reproducibility, we try to use open source software for analysis. So we used R, and in particular the tidyverse collection for data manipulation and the runjax package for running the Bayesian modeling. So basically everything is stored in this GitHub repository. So you see that we have a bunch of models here, and then something that is called main, and we have data provided in an Excel file. And you see this file which has this extension, our approach. I don't know how many of you are familiar with R, but this is the way we create things as R projects. And all this effort of creating an R project instead of just using a bunch of scripts is for making things easier for the final end user of our analysis and code. So what you need to do if you are interested in running these scripts is to go in this button, and instead of open in desktop, just download everything that is contained in the repo as a zip folder. Then once you downloaded everything and everything is saved under that one directory, you can, let's say for instance, I download the repository and unzipped in my desktop. So this is just the download of what is contained in the GitHub repository. And once everything is downloaded in whatever location, so all the this building of the R project is to avoid any specific reference to any path in your directory. You save this whatever you want, then you open this file with the RProj extension, and you end up with this. So you see that now opening this hard project file, you can open the BLCM main script and you can run the codes we prepared. So you see that I didn't set up any specific directory, but if you run get working directory, you see that my directory is in the desktop. Then you just run the libraries. And then you source whatever code you want. For instance, we can run the script, which is the main analysis. And this is what our model leaves. We just source the model we want. Then you go through the data, loading the data. You just need to run. And then you have some options here. For instance, we set up the first week of observations because we have that RT-PCR and antibodies are measured within different weeks. We select the immunoglobulin G or M, but we can also pick up IgM and IgG alone. And then we see that we end up with these 4 studies. And we have the cross-classification of results between PCR and antibodies in these 4 studies. Then we have a little bit of transformations for making things easier for our ranjaks. We set up the initial values, and then we run everything. Okay, then everything is computed, so we can print our results. And okay, and then these 4 lines of code were added today. And then we can, for instance, plot our results. So here we have the sensitivity for RT-PCR and the specificity for RT-PCR. And then for lateral flow and immunoassays sensitivity and specificity. Yeah, okay, and so let's say you want to analyze the data for the 2nd week from symptoms onset. You just need to put 2 here, and then you maybe want to just see IgG, and maybe you want to put specificity equals 1 to RT-PCR, and then you just use this code. So we went to the data once again. Just executed the code, and it takes a while. So here our results. And of course, here we have one for specificity of RT-PCR. And once we plot, we have an error. And we have the results, for instance, for lateral flow immunoassay, sensitivity, and specificity. So you just basically download the content in the folder and just run the code with some modification. And we see, for instance, here the code when we have some prior specification, and when, for instance, we put a prior of 1 in the specificity of a RT-PCR. So I think that I'm done. So I wanted just to communicate that this is not perfect. So maybe it should be a bit improved, maybe a bit more documented. And if you want to have more information, please reach us. But of course, it's a basic template that you could also use with other data using 2 populations and 2 tests. And of course, we have also other models that you can source with taking into account dependencies, conditional dependence between the 2 tests. Okay, I'll stop share now.
Okay, thank you, Paolo. Paolo did a great job putting together all the codes that we used for this and all the different prior specifications that we used for this paper. If you look at the paper, you will see that you can run every part of what we're presenting there and see the results for yourself. Now Sonia is going to interpret what we found out about doing this analysis for COVID-19 tests. So Sonia, the floor is yours.
Yeah, thank you, Polychronis. Yeah, it's my pleasure to switch now and show you the interpretation of the results from our study. As Polychronis and Paolo already indicated, our aim was to estimate the diagnostic accuracy of the RT-PCR and an immunoassay, the lateral flow immunoassay test, depending on the week post-symptom onset. And to get suitable data, we started with a literature research. And as a sort of a repetition, what Paolo has already shown to you, out of all the studies we looked at, finally, there were just 4 studies with suitable data. And here you see again the cross-classified test result, the frequency of the patients, like in week 1, in week 2, or in week 3, of the different studies which we took as different population. And here you see the different combinations of positive and negative test results. More in general, RT-PCR and the lateral flow immunoassay, RT-PCR has been used as a reference test for COVID-19, although it is known that it's not 100% sensitive. Sometimes the sensitivity could even be considerably lower. And it's also known that the specificity does not always reach 100%, so it's possible that they are false positives. The lateral flow immunoassay is able to detect IgG and or IgM. And in a number of papers, immunoassays, not only the lateral flow, but also other types, have been evaluated against the RT-PCR. But as you've seen, this is questionable, and there's also a paper which appeared, which is questioning, should we really use RT-PCR as a gold standard? Because if you do so, compare a newly developed test against a test which is not 100% perfect test, then you will have biased results. But this was done a number of times, and this was also one of the motivations why we undertook our study. What is known is that the median seroconversion for COVID-19 is about 10 to 12 days post-symptom onset, and there is a rapid increase in the antibodies after day 6. And this also was one of the reasons why we decided to stratify our analysis for the different weeks. And it's also well known that for this immunoassay, the sensitivity is not equal to 100%. The specificity is also not equal to 100%. It's known that there are potentially cross-reactions to other coronaviruses, or it's also described that there might be a cross-reaction to a rheumatoid factor, an IgM. And when looking more in the literature, what is available with regard to the variability over time, we found this paper from Setoraman, who combined different studies in a qualitative manner and came up with this plot showing in the y-axis the probability of detection. So what you can see here with the solid lines is the RT-PCR, and the colors are due to different specimens which were taken. So looking at particularly the first 2 weeks, you see that there's quite a higher probability of detection, and then this decreases slightly, whereas for the antibody detection, which is marked with dotted lines in violet and green, this just starts later. And as you've seen already in the analysis shown from Paolo, the trace plots, when we run 3 chains in parallel with different colors, so green, blue, and violet, so you see that they are well overlapping, looks like they are well converging. We run this over 100 iterations. On the left-hand side, you see the sensitivity, which is well close to 80%. And on the right-hand side, you see the specificity, which is even below 95%. For the week 1, also the posteriors for the lateral flow immunoassay. Here, the sensitivity is relatively low, just close to 30%, but the specificity is higher compared to this. And combined, of course, you can also have these quantitative approaches showing medians and 95% probability intervals. So what we can see here from one model, which we considered without taking into consideration conditional dependence, that the sensitivity of the RT-PCR remains constant, so close to 70% in the first 2 weeks, and then slightly decreases. In contrast, the sensitivity of the immunoassay starts relatively low. I mean, it's just the first week after the onset of the symptoms, close to 30%, but then decreases into the second week and also when it goes to the third week. In contrast, the specificity of the PCR is close to 100% and remains also constant, although, as you've seen, the sensitivity of the immunoassay varies quite a lot. The specificity of the immunoassay starts a little bit lower with 96, but still it's relatively close to 100%, and then increases in week 2 and week 3. So both tests have a high specificity, and the median, these point estimates of the RT-PCR are always higher compared to the immunoassay. And when we consider another model with conditional dependencies, the estimates change a little bit, they're slightly increased. And when we look below to the rows with CDP and CDN, so this indicates the conditional dependencies between the sensitivities or the specificities. Most of them include the 0. So this would say that there's not a strong evidence of conditional dependence in this case here, and we could stick to model A. So as a conclusion, to the best of our knowledge, this is the first time a Bayesian latent class model analysis was done for COVID-19 for the simultaneous estimation of sensitivity specificity in the absence of a gold standard. Our model, like with the 4 populations, 2 tests, was a fully identifiable model. As you can see in the source files, or you can also repeat it, we did also a sort of a sensitivity analysis, so exploring the influence of priors. A number of diagnostic checks were done about the convergence, or as you can also see in the run-jack codes, and we also included the potential of the conditional dependence. So in our analysis, the medians or the specificity of both tests were close to 100%, but the median specificity of the PCR was higher than the immunoassay. The sensitivity of the immunoassay increased from week 1 to week 2 and week 3, whereas the sensitivity decreased slightly in the 3rd week. So all of this is completely in agreement with the knowledge we have today. As a sort of limitation, I would like to state that we screened a lot of study, but there were just 4 where we found suitable data. And still in these 4 cases, it's well possible that the PCR was performed in a different way, potentially different targets, or a different cutoff for the CT to be considered positive. The patients might have been selected in a different way. And this is somehow astonishing that although this is such a big pandemic, that there are so few attempts, and to our knowledge, no attempt using BLCM with this. Of course, at best, we would have data which had been collected on purpose to do such an analysis. We think that the BLCMs provide a flexible and a valid estimation framework, and we think that in future, the BLCMs should be part of the surveillance studies, in particular of the ongoing serological studies, and also as part of the preparedness of the next pandemic. So here you can see the references which will be in, and with this I thank you, and please start with comments or questions.
Okay.
Polychronis, could you take over to moderate?
Yes, I will. I'm just trying to, you should stop sharing your screen.
Yeah, I stopped.
We're back here. Thank you very much, Sonia, for this elaborate discussion of our results. We're looking forward to any comments or suggestions. We have here a few comments in the chat line. But before that, I would like to ask Professor Walter to also join us if he wishes to make a comment. As I said before at the beginning, we are honored by the presence of Professor Steve Walter. Professor Walter is the Walter in the Huey and Walter paper. So still, if you like to say, thank you very much for joining today. If you have any comments or suggestions now or later on, please, we'd be more than happy to hear from you.
Yeah, okay, sure. I'd just like to update you a little bit on what's been going on in North America in this regard. Not directly on what was spoken about just now, but I think probably an area where statistical methodologists could be very helpful. And what I'm thinking of is actually group testing. This has been in the news quite a bit recently because one of the big problems that we're facing, and I think in many countries, is the capacity of laboratories to process all the specimens that are coming in. So the basic idea, if you haven't heard of this before, is that you take a number of samples, swabs or blood samples from individuals, say 5, and you test them as a group. And then if the test for that group turns out to be positive, then you can infer that at least one of them in that group was indeed a positive, and you can then go back and investigate them individually to identify the positive people. That's sort of the simple conceptualization of this, but of course, as always, there are complications, and one of them seems to be very much that the sensitivity of the group test will depend on the group size. Which sort of makes sense, because if you think about it, if you had a very large number of samples pooled and only one of them was positive in truth, then presumably your sensitivity is going to go down substantially. So that's an area of work right now to look at that, to actually identify the sensitivity of the laboratory methods according to the group size. And somebody mentioned the possibility of false positives, which I hadn't heard of previously, but obviously that's another complication that would come into play. And just finally, I think we do have to think about, in the longer term, looking at prevalence estimation. Up to now, of course, the focus has been very much more on the identification of positive individuals. So even if you have group testing, the public health authorities are still very much wanting to go forward to a second stage and test the individuals and find out who the positives are. But in the longer term, I think we're talking about wider scale community surveys to establish the prevalence of COVID, and hopefully that will be very small. And so then, of course, the efficiency advantages of group testing will come very much into play. And we, at that point, may not actually need to go on and identify the positive individuals. It may simply be a matter of identifying the prevalence or estimating the prevalence. Much has happened with, in the old days, for HIV testing. In that particular context, there was concern about confidentiality, and there was a very sensitive topic, of course. So in fact, there were prevalence surveys done like that that did not identify the positive individuals. Just one final comment on the last presentation, when you said that I think the sensitivity of one or more of the methods was going down a little bit in week 3. The way I looked at that table, the confidence intervals were still quite wide, and relative to the changes that you'd seen in the estimates themselves, I would actually be hesitant to say that. It seemed to me that the actual estimates were very constant from week to week. So that's all I have to say. I'm sorry, I turned off my camera. I just realized.
Yeah, you should have your camera on, but
Here I am.
You're up in the mountains.
I'm in Scotland, it looks like. I wish I was.
Okay. Yes, thank you for this. We weren't aware about the pool testing. This goes back, I think, to 1964. I think Dorfman was the first one that did this for syphilis in the soldiers.
Actually, your dating is very inaccurate. You several times said that our paper was in 1990. It was in 1980.
1980, yes.
Yes, yes. And Dorfman was actually 1943, not 1964.
Okay, but this was the first
so
time.
You're off by 20 years there.
Yeah, I don't remember the dates. But I think Dorfman was the first one that did pool testing. And obviously there is a lot of room to apply this in this case. especially at the second step, when we are going to screen populations which are of low prevalence, and in this case, that would be much more effective, and the specificity of the test would probably be up to 100% when it comes to pool testing. Of course, the sensitivity would be lower, but due to the dilution effect. But nevertheless, for disease-free population or low prevalence populations, pool testing is a cost-efficient way to move forward. And regarding the specificity of the PCR, the test, of course, the specificity is almost perfect, undoubtedly. But when the case would be for screening at the second step, as I said, for screening healthy populations or populations with very low prevalence of infection, then we may have also to consider the case of false positive PCR test, because in these cases when we are testing 10,000, okay, and find 10 positives, some of these positives may be false positives, and this should be accounted for in the future when it comes to restrictions, etc. I don't know if anyone else would like to comment something. Sonia, Paolo, would you like to say something?
Yeah, I think that there might also be a variability, so that in the phase where there was the large increase in cases and the labs were just overwhelmed, that then I read in some papers, they even, just to make sure that they get every single individual, that they also considered cases as positive with very high CT values. But this might have changed over time when more tests were available. So of course, this we also did not consider in our model. And I think there were many lessons learned throughout the last months about these newly developed tests.
Yes, thank you. That's true. Should we go to the chat and see the questions that have come up? One first question was about the Bayesian part. The Bayesian part is about using priors together with the data. And it is necessary, absolutely necessary, when you have a model that is not identifiable, which was not the case here for the model of our primary analysis. But there are other cases that you need to have informative priors, and the best way to do this was with Bayesian analysis. We didn't get into the details of this. There is a lot of material in our site that you can go and explore, presentations and software ready to use. But the focus was not on explaining explicitly what Bayesian analysis is about in this short webinar. A lot of people are asking about the recording of this event. Yes and no, because I forgot to start recording while I was presenting, but you will have Sonia and Paolo. So I will send the half of it, the second half of it, to anyone interested, and also see if it's possible to upload it on YouTube. But I'm afraid that the first part was lost. But it's okay, we have the 2/3 of the webinar. Marcus says that typically one would have two populations with different prevalences and two tests, and in these two populations, one would have different proportions of true negative results. In our analysis, you report patient data from week 1, week 2, and week 3 post-clinical onset. So where are the negative individuals? Yes, perhaps Sonia could say more on this, but we filtered the studies and identified 4 studies that also have testing of positive and negative individuals. Sonia, if you could elaborate more on this. So as you see here, these cross-classified results are not only from the clinically affected, but also for individuals that have been tested but are negative individuals. I don't know if this...
I think this was, and definitely that's a weakness, a limitation of the study. But again, this comes back to the lack of data. We tried to have as homogeneous groups of patients as possible, but it can be that in the 4 different studies, the patients were not selected exactly in the same way. That's well possible, but we tried to look that we only included study where there were patients with COVID and patients without. I think this is the best what we could be doing. But as you see here, for example, there are a few people who are negative for both tests. Yeah, so I think these cases are included in the models. Okay.
Maybe can I just speak into this? Is it easier?
Mm-hmm.
Is that okay? Yes, okay. The question is typically if you say you looked at patients, at COVID-19 patients for 1 week after starting of clinical symptoms, 2 weeks, 3 weeks, you would in that model also would have to have patients that were COVID-19 negative. So how did you, or how were they included, and how did you decide which week to put them in? Because they didn't have a certain time from COVID-19 onset of clinics. They didn't have clinics, they didn't have COVID-19.
Yeah.
In a typical 2 population model, you would have in your in the high and the low prevalence group, you would have individuals that are not infected. So I currently don't understand how these ended up in your 1 week, 2 week, 3 week category without any infection. There I'm seeing a lack of individuals that were truly negative, even though we don't know the status, but they were truly negative, and where they ended up in your analyses.
So
Yes.
Maybe would you reply, Paolo?
I don't know if I understood correctly. So,
well, typically in 2 population models, you could even have an extreme that your negative population is in truth has 0 prevalence. Yes,
Okay.
there are no infected individuals in your negative population, and all of your truly infected individuals, based on your definition of low prevalence, high prevalence, are in the high prevalence population. Then you run your 2 tests on both these populations. In reality, you will have a mix where you in the lower prevalence population, you will have a higher proportion of truly negative, even though we don't know that, but they are in fact truly negatives. And I don't see how in your model with where you have these truly negatives, where you have the information you're truly negatives on,
Okay.
specifically if the studies come all from COVID-19 patients that then were subjected to the respective tests, and you could identify the time from onset to week 1, week 2, week 3.
Okay.
yeah, but we know that. So I don't know if I kept the question, but we know that these patients had some symptoms experience, but in the end, we know that we have a subset of patients we can define as no COVID-19.
Yeah,
Based on what?
Maybe, Marcus, maybe I could also, so you can look, all the references are in, and
Okay.
for example, for the first one, for the Garcia, you see in the 2nd week, there the numbers of 15 and 3. And there, for example, they have here a group of patients which had a pneumonia of unknown etiology and negative PCR. So we took this, and this were a group in this paper. Yes. From Garcia. So we also tried with regard to the healthy ones. This was a critical bit. Therefore, I think this is the reason why out of these more than 400 papers who report data on patients, we finally just found 4. Sometimes it was an issue to find the good controls. We excluded them also if they were completely unrelated. but at least in these 4 papers, I think they try to make an effort to have patients included in whom it might be likely that they had COVID, but potentially another pneumonia.
Yes, I mean, the basic, okay, obviously, Marcus, that's why from 448 studies, we ended up with only 4, because we were looking about evaluation that were using PCR as a reference test, but we all have healthy and infected individuals, and most importantly, healthy individuals that were valid controls in the way that they should be valid under another class model. For example, we excluded studies where the healthy individuals were the ones that were before the onset of COVID-19. So healthy individuals, as Sonia said, were a subsample of patients that were PCR negative, and ELISA positive or negative doesn't matter. We were based then on the cross-classified results to estimate the true prevalence. We don't discriminate in the model between healthy and infected ones, but we're looking for suitable studies under a golden standard, of course, that can be used in a BLCM setting.
Okay, but then your estimates all relate to patients with clinical symptoms, either related to COVID-19 or similar clinical symptoms, but not COVID-19, including the prevalence estimates, including sensitivity and specificity estimates for the tests. They can be extrapolated to patients that have clinical symptoms in one way or another, irrespective of whether it is COVID-19 related or not, and not the general population of healthy individual sensitivity and specificity, right?
Yes, absolutely.
Okay.
Yes, of course. The target population here is the population of patients that entered the hospital with some kind of symptom, whether it was COVID or 19 or not. Absolutely. And one of the reasons of this webinar is to attract the interest and try to collect relevant real-life data for the general population. Absolutely.
Okay. But yes, as I said, it might not just that we all understand that limitation or that specific interpretation way of interpreting your sensitivity, specificity, and prevalence estimates.
Yes, absolutely.
Okay, good.
Absolutely.
Yeah, but I think that there are other comments in the chat. So I think that the main focus was to estimate the accuracy of the test. And of course, the main goal was not to estimate the true prevalence of COVID-19 in the general population. Otherwise, probably other kind of patients should be included. So I see that. So I think that we are trying to see if lateral flow immunoassay or RT-PCR makes clinical sense once you suspect COVID-19. So I can agree that from our study, it's difficult to end up with an estimation of the true disease prevalence. I mean, from just picking up the estimate for the prevalence.
Yeah, absolutely. Yes, of course. The target population here, the source population, which tells us a lot about the population, are the people, the patients that were tested in a clinical setting, obviously. But this is the sensitivity and the specificity estimates are relevant to this source population right now. If we have relevant data from the general population, we will be happy to analyze them and they provide sensitivity and specificity estimates for the general population, of course. And that's the idea, that when the people should provide more data, and we could provide sensitivity and specificity estimates for low prevalence populations, for disease-free populations, or for the general population in a heavily infected country. Okay, another question is whether we have considered LOD and LOQ of each type of test. I assume that you are meaning the limit of detection and the limit of quantitation. Yes, these are analytical properties of the test. We assume that the test, of course, they affect the diagnostic sensitivity and specificity, but this is not, from a clinical and epidemiological perspective, the target of this analysis. I don't know if someone else would like to say something more. The limit of detection, I know that the limit for detection for COVID-19 tests has been set pretty low, okay, because we are interested in improving the sensitivity even at the cost of specificity. I know that the CT cycles for PCR, perhaps Sonia can tell us more, are up to the up threshold. I mean, it's more than 32 or 34, which makes it a very sensitive test.
Yeah, I agree. I think conceptually, as you said in the beginning of your presentation, conceptually it's important to make a distinction between analytical and diagnostic sensitivity and specificity. And here we are really based and focused on the diagnostic side. Of course, this is not completely independent to the analytical side, but it's also, you can have a diagnostic test which is highly analytical, but this does not mean that you also have a high diagnostic accuracy. And our focus was the diagnostic side.
Yes, that's true. Another comment comes from Cheryl, whether there is a good current code repository for other combinations of information. The answer is yes. It's the one that we have already in place in our website, which will be continuously updated. Let me share the link one more time. You can find there all the training material for the first from the first school that we did in Athens 6 months ago, and this will also be continuously updated. So this is where, okay, why did I should send this to everybody. Sorry, everyone. Okay, so this is our webpage where you can find links, and perhaps I should also share the mailing list, okay, about this type of models, which if you wish to join, everything that we make available, or every training session we hold will appear in this mailing list. Another question comes from Vasilis. Vasilis, can we use this model to calculate positive and negative predictive values? Yes, we can use it. The positive predictive value, the negative predictive value, I would say, is a byproduct of the sensitivity and the specificity and the true prevalence. Essentially, they're not specific to the tests. They also depend on the prevalence in the target population.
Yes, exactly.
Yes.
Yeah, I was wondering. Yeah, I think calculating PPV, I think is more useful, because this is the probability of someone has the disease if it is positive, depending on the prevalence of the population. So, but in your model, you have taken informal prevalence, so you don't know exactly what the prevalence is, right?
Yes, but we also estimate the prevalence, which means that at the end we would also calculate the PPV and the NPV for each of the 4 studies.
Right.
I'm just saying that this is not necessarily relevant to any other population, as Marcus discussed before, okay, because positive and negative predictive values change depending on the prevalence of the population under consideration.
Yes, of course. Yes.
But the sensitivity and the specificity can be directly extrapolated if the new target population has the same attributes with the population that we used in this setting.
Yeah, I agree. But I think that it would be this model would be more useful if you give a more precise estimate about the prevalence of the population. Don't you agree?
Yes, absolutely. We could also incorporate prevalence estimates in our results. But since within a diagnostic evaluation setting, prevalence is a nuisance parameter, we chose to not include this. But yes, you're right. We could think, while review the paper to add the prevalence estimates as well. Yes.
My second question was about using raw data, because I've noticed that you had taken summary data from different studies. Can you run this modeling with raw data? Have you thought about it?
We are more than welcome. We are looking forward to raw data to run this model. Ideally, these models should be with data that are collected specifically for this purpose. Absolutely, we're looking forward to this. Yes.
Yeah. Great, thank you.
May I just add to this? Yes, I mean, this was just the solution. We only found these published data. Of course, the ideal situation, we would have raw data, and the additional advantage would be, as you can see in the previous trainings, we could also include covariates on this, which is not possible now, but there are models who can do this. And we could also, of course, include the estimate of different prevalences or the adjustment of prevalences if there are specific covariates, or if you have specific or different centers. We could also work with random effects at hospital level or at whatever other unit. So it's just, you know, the problem is there's a lack of data, and I think we have a nice methodology which we would love to use more. But I mean, it was quite disappointing to go there and just to find 4 data, and even, there are always some limitations. We do not know if they were applied exactly the same way, the PCRs. We do not know about the patient selection. I mean, the aim of these studies was not to give a good basis for BLCM. They publish it for another reason. But this is why we are so keen to have raw data.
Yeah, no, I agree. You will have much better estimates if you get.
That's what I'm looking for. You are looking forward to it. I mean, hopefully we have data specific for these types of model. We are going to have more relevant estimates, absolutely. Okay, another question from Dr. Karna. What is happening in lateral flow immunoassays which are depending on donated RT-PCR kits? The PCR kits being used in testing have different sensitivity and specificity. They come from countries of manufacturing. How do I address this issue in my analysis? In your slide on data, you have 4 papers in week 1-4. Will be share. If I'm getting this correctly, if I'm not getting this correctly, please correct me. But I don't know. We assume that first of all, the lateral flowing, we are not considering any LMIC methods here. Okay, and lateral flowing immunoassays were based on antibodies, which were conditionally independent with RT-PCR. Because generally, in principle, you are expecting methods that are based on a different biological principle to be conditionally independent. If this does not cover what you were asking, please send an email. Sorry, I don't know if anyone else understands better what.
Polychronis.
Yes.
So what I was asking was, in Nepal, for example, in low and middle income countries, many times we depend on the donated RT-PCR kits from different countries, and they vary substantially in their sensitivity and specificity. And when you were using that and making an analysis, so I was asking, like, how do I address those differences in sensitivity and specificity of different products and making a single analysis together?
If the tests are based on a different principle and you feel that the sensitivity and the specificity is different between the tests, is this what you're saying? Yes.
Yeah.
Right? You should adjust for the sensitivity and the specificity for each test when you're estimating the true prevalence of the positive and negative predictive values. If you have markedly different sensitivity and specificity estimates between the tests, then the assumption of constant sensitivity and specificity is violated, and you cannot use the models we are using here. An implicit assumption is that the test is the same across studies, or at least of comparable sensitivity and specificity, so as to be able to, for the assumption of constant sensitivity and specificity to hold between the different populations. Otherwise, you have a fully non-identifiable model and you are heavily dependent on priors, which is not something that I'm really fond of, to be perfectly honest with you. And this is a personal opinion.
Okay, so I think I'll get back to you through email, and then we can have a chat over it.
Okay. I think I skipped a question from Professor Walter. So also, is there a linkage between weeks 1, 2, and 3 at the individual level? I assume that you're implying whether they are the same individual measured twice or 3 times, right?
Yes, that's right. I'm guessing
kind
that you actually did separate analyses for the data at week 1, then week 2, week 3, without linking them, and that's presumably because of the nature of the data that you're able to get.
Yeah.
But obviously, it'd be better if you can actually have the individual level data and link it from the 1 week to week 2, week 3.
We don't have the, Sonia and Paulo have more on this, but I'm pretty sure that we were confident for the 4 studies, that's why there are only 4, that we don't have dependency, meaning that it's not the same individuals measured across time. Because we were, that's why we got down only to 4 studies.
Oh, okay, but I thought in the tables, it looked like there were quite similar frequencies in like the week 3 or the double positives and so on. I was assuming they were actually the same people.
Yeah, so there are the same people, but of course we have only marginal data, so we
right, yeah, that's what I thought. So my question was related to what somebody else asked, that you really would like the individual level data if you can.
Yeah, absolutely.
Yeah.
Having the individual level data would allow us to have a model, a panel model across time, which would be a lot more better, but we don't have the individual data, as you know better than me, of course.
Right. Mm-hmm.
Okay. Yes, absolutely. The prevalence estimate does not apply in the general population. Okay, absolutely. That's what we said before when discussing with Marcus.
Yeah, and in fact, also, it's not just the prevalence, it's everything.
Yeah, absolutely.
Marcus, I think, said the sensitivity and specificity properties could be quite different if you move from a high-risk population or a partially symptomatic population to the general population.
Absolutely. And this is why we need latent class model to readily estimate sensitivity and specificity under each setting. That's the basic idea behind all this, that we should continuously have sensitivity and specificity elements that are directly relevant to the population understanding. And BLCMs is a very intuitive approach in doing it in a very fast and cost-efficient way. Absolutely. You cannot extrapolate this sensitivity and specificity estimates to New Zealand, who is supposedly disease-free right now, right? But you can have a new cross-classified results there and have a valid estimate within a very short time. That's what we're proposing in this consortium, Harmony, and with the use of these BLCMs, absolutely.
Can I ask one more question?
Yes.
That's it. Have you tried to compare your model with a meta-analysis model? Have you done?
Essentially,
because I think it's possible to do a meta-analysis, isn't it, with this data?
Yeah, absolutely. Paolo is an expert in meta-analysis. We'll tell more on this. Essentially, this is a hybrid model because we're filtering the data, okay? And we have selected 4 studies, which if you use PCR as a reference test, this is a meta-analysis. But if you are not using it as a reference test, you are using it to estimate sensitivity and specificity. There is also a setting that you can do a latent class meta-analysis if you are asking this, right? Mm. But the number of studies is small to do this. It's only 4. If you really want to filter, and we chose for this to go by week because it's very relevant from a diagnostic perspective to have sensitivity estimates by week.
Yeah, yeah, okay.
Yeah, I think that it's a good suggestion. Maybe we could try to run some diagnostic meta-analysis and see if even by chance the model fits well, if there are meaningful differences. And maybe, so I was thinking about diagnostic meta-analysis, but so the literature is a bit overwhelming, and it's increasing at an impressive rate. So maybe if you are interested, we can try something, I don't know, maybe taking the data from published meta-analysis and do what we can do considering RT-PCR as an imperfect reference standard. And I must say that, so I would encourage people to share ideas and build larger networks, because for me, observing the research efforts in these months, it has been a bit disappointing to see few people collaborating in a small group, competing with other small groups to publish something, I don't know, before others. So I don't think that this is research for the good of society.
Yeah.
So I think that we should try to fix this as much as we can. So if you have, I think that, I don't know, if you have ideas, we can maybe collect a larger effort. I don't know, maybe having on board different people, maybe people that discuss findings, people entering data in the Excel file, literature screening, modeling. So, but I think that we need a larger and more comprehensive effort.
Yeah, the reason I asked is because you don't make any particular assumptions about the prevalence. So I thought maybe they give, if you try a meta-analysis model like a random or mixed effects model, maybe you get similar results. But okay, then you have in your model you have the advantage that, as Polychronis said, to take into account the time dependence from over time. So yeah, it's okay.
Under the Harmony action, we are building 6 or 7 teams that will deal with different aspects of evaluation of diagnostics. If you join our mailing list, once we have the basic teams in place, we will issue an announcement asking more people to join one of these teams, whether they would like to contribute. And
okay.
yes, so, and in relation to the specific study that we did together with Sonia and Paolo, we're trying to expand this and include more data and more people, and perhaps provide sensitivity and specificity elements that are relevant to different clinical settings or for the general population. So send us an email, join our mailing list, because the idea is that we'll keep broadening this.
Yeah.
So this is just the first step.
Yeah, sure. How can I find this email list?
I sent it. I sent the link to the mailing list. I can send it again, or I can send it personally to you.
Yes.
Berwin asks, why would sensitivity and specificity of tests depend on the population? This is a long fight between epidemiologists and microbiologists for a long time. The diagnostic sensitivity and specificity of the test, from an epidemiological perspective at least, is different depending on the target population. because the diagnostic sensitivity and specificity it has nothing to do, of course it has a lot to do, but it is not related to the analytical sensitivity and specificity. Analytical sensitivity and specificity is how well the test is supposed to work in the lab. It's about the repeatability of the test, or how well it is measuring what the test is supposed to measure. Okay, but from an epidemiological and clinical context, the sensitivity and the specificity depends on the target population. If you have an immune population and you have an antibody test, then the sensitivity of this test in this population is not good, because it is measuring something that is corresponding to immunity, not to active infection, which is not the case in a disease-free population where the epidemic has just entered. So obviously, for each type of test, we need a different sensitivity and specificity depending on the epidemiological setting. I don't know if Sonia or Paolo would like to say more on this.
Oh.
Yes, I think it has been well described also in human medicine. I'm a veterinarian by background, that the same diagnostic tools differ compared to primary, secondary, or tertiary healthcare, because the spectrum of the patients which enters differs. In veterinary medicine, I would bring an example of very young animals which have been kept under strict biosecurity measures. They will have seen much less infections, pathogens, or else. And when you compare the performance of a diagnostic test in the group of young animals versus very old animals which have been in different places, of course there are differences with regard to cross-reactivity. And a test might be then less specific in a group of older animals, or if the majority of this population is vaccinated. I think there are a number of reasons why sensitivity and specificity differ with certain characteristics of a population.
Okay, I'm just resending the link to the mailing list for Vasilis and anyone else interested. Okay, another question. You could certainly take the data from our Cochrane COVID antibody review published last week from Yemisi. Happy to do this. Please share the link for everyone in the chat, and we're definitely looking forward to it. Please also join the mailing list. You may be interested in joining our network as well. This is a free network. The Harmony Network is an EU-funded consortium. So far, we have 45 countries, and we have training possibilities for practically everyone, most of the times funded, depending on the budget we have. In most of the cases, we have budget for every trainees and for trainers. Feel free to join our network. We would be happy to have you on this one.
Yeah, that's great. So I'll put the link in the chat. But the good thing with Cochrane Reviews is that you can download the data from the website as well. And I mean, there was a lot of rubbish studies in this version, but we're seeing more and better studies coming out now. So actually the update of the review, which we hope to publish in July, will probably be a good data set for you to download, and maybe you can find some useful studies in there to expand what you've done so far.
Okay, great.
Absolutely. If you can share the link, we would be more than happy to inspect it, and you are more than welcome to join us, both in the network and this effort to expand these methods and use more data.
Thanks. I'll look into that. Oh, yeah.
Okay, just send the link though. Okay, diagnosis advice with, yes, absolutely. Cheryl, sorry, let me see now. It's something like, Anastasia is saying it's something like politics and science. I wouldn't understand what this is, but Sales says that diagnostic tech performance also varies with age structure, access to healthcare, avoidance of healthcare, spectrum of disease, severity, stage of disease, quality of collected samples, transport time. Absolutely, I agree 100%. Although I would put transport time and quality of collected samples partly in the field of analytical sensitivity and specificity. But definitely, we agree that sensitivity and specificity varies definitely with age and access to healthcare and spectrum of disease, of course. Sonia also said that. Okay, Yemisi also shared the file to the Cochrane study, the link to the Cochrane study. Thank you very much for this. Any other questions? Because I have came down to the chat. Any other comments, suggestions for anyone? From anyone? Professor Walter? Paolo? Sonia?
I'm fine.
Okay. No, nothing. So thank you very much for joining today. Thanks a lot to Sonia and Paolo working together on this. We're looking forward to expanding this in the future and making it a useful tool for COVID-19 and for other infections as well. So I don't know if Sonia and Paolo would like to say something to our...
Yeah, thank you very much. It was a pleasure with you. Also nice questions. Yeah, and looking for further collaboration.
Yeah, thanks a lot. It was great to working together and also to chat with all these people in this webinar.
Okay, then this is the end. Thank you very much. Bye-bye to all.
Thank you.
That's it.
Εντάξει.
Να
μην είχε ξεχαστεί και λέω δεν θα βγει ο φως. Τι κάνετε, καλά?
Κάτσε να σταματήσω το recording.